Thank you very much, Mr. Chairman, for your invitation to give me the opportunity of talking about the French paradox. Now, this is a very long story, the story of French paradox, but the saga started really in 1992 with the publication of this paper in the Lancet journal, where for the first time scientists proposed a relation between coronary heart disease, epidemiological data, platelet, the risk of thrombosis, alcohol, and wine. And also for the first time, the effect of alcohol were not presented as toxic. It was really the first time. Now, the definition of the French paradox. We have to understand that. We have to put in relation any conventional risk factor with mortality from coronary heart disease. As you know, there is usually a positive relation between various risk factors. Here we have used dairy fat, but in certain circumstances, certain countries do not fit with the correlation. For instance, France here, or UK, or even Switzerland. This is what we call the French paradox, but we could say UK paradox too. Now, this is another definition by Finnish investigators, and they use cholesterol saturated fat index along the horizontal axis against coronary heart disease mortality, and again France did not fit, and this time Finland too did not fit. Well, it is a paradox or not? It is a paradox only if we adhere to the theory that saturated fat or blood cholesterol are causal factors in cardiovascular disease. If you do not accept this theory, of course, there is no paradox. I will not discuss that issue, but you know that there is an endless controversy regarding the role of saturated fat and cholesterol, because the main factor controlling blood cholesterol is saturated fat intake, and this is a meta-analysis published in the American Journal of Clinical Nutrition in 2010, saying that there is no scientific evidence for concluding that dietary saturated fat is associated with coronary heart disease. Now, what is the French paradox at the present time? This is a paper published in the European Heart Journal in 2008, reporting the statistics in the different European areas at the year 2000. Here are the different countries. This is the mortality from coronary heart disease, the scales and the color scale. And you see that obviously France is a paradox. This is for men, age group 45-74. Now, if we look at the data regarding stroke deaths, again, France is special compared with the other countries, including countries located in the south of France. This is the women and stroke deaths. Again, you see that even areas located in the south and supposed to be at low risk, for instance, Greece here, or Sicily, or Portugal, at higher risk than France. Well, explanation of the French paradox. There are many explanations have been proposed. Sometimes these explanations were quite stupid. For instance, some epidemiologists say that death certificates were not correctly filled by the French doctors, or some statistical mistakes by the health authorities. But if we look at the more serious explanation, it is interesting to discuss a little bit what we call the north to south gradient. Is it normal or not? A different way of questioning is France a Mediterranean country, or are French protected because they have adopted a Mediterranean diet? And number 5 is the wine drinking hypothesis. Why discussing the Mediterranean diet? Because it is the best evidence we have regarding the relation between cardiovascular disease and diet and the dietary habits. We have so many papers now, not only randomized trial published in 94 or in 99, but also very recently in the New England Journal of Medicine in 2013. This is randomized trial in secondary prevention or in primary prevention, but there are also so many studies, epidemiological studies, reporting an inverse relation between adhesion to the Mediterranean diet and the risk of cardiovascular disease, including in countries that are not Mediterranean. We even have a meta-analysis published in 2010. Definitely, in terms of evidence-based medicine, the Mediterranean diet is protective. Now, the question is, are the French Mediterranean people? Or another way of discussing is to say, if there is a north to south gradient, there is a proportion between the distance, north to south, and the risk of cardiovascular disease. For instance, you see here, London and Paris are close, but in terms of geography, but there is a striking difference in the mortality from coronary heart disease. In contrast, Paris and Montpellier in the south of France, 1,000 kilometers, and the same rate. Also, Montpellier in the south of France and Roma, close, but against a difference between the two areas. This is quite surprising. Now, if we look at the data within France and the different regions of France, this is very surprising to see that Paris and Montpellier do have the same mortality rate from coronary heart disease. But more surprising, the fact that the lowest mortality rate is not in the south of France, but in the Poitou-Charentes area. Where is Poitou-Charentes? It is in the west coast of France, and not in the south. And as you know, it is a province where people love butter, saturated fat, and also they love salted butter. And we have both saturated fat and sodium, and we have the lowest mortality rate from coronary heart disease in France. Now, is France, in a certain way, a Mediterranean country? If we say it is a Mediterranean country, it means the dietary habits are a certain way Mediterranean, means the foods are Mediterranean, means the agriculture is Mediterranean, means the climate is Mediterranean. It is not true, of course. Most of the French territory is under the influence of the Atlantic Ocean or from continental climate, and only a very small part of France is under the influence of the Mediterranean climate. We have discussed all this issue in a paper. It was an invitation from the European Society of Cardiology. You can find that in this paper. But we can conclude that the hypothesis that the French are relatively protected in the same way as other Mediterranean is obviously wrong. Now, I am going to discuss a little more the wine drinking hypothesis. Now, come back to the relation between saturated fat or diet fat and mortality from coronary heart disease. Here, without adjustment for wine drinking, you see that France doesn't fit, UK doesn't fit. But if we add in the equation wine, you see that France is on the line, UK is very close to the line, and also Switzerland is on the line. Despite that, there is still a large difference between UK and France. This is an explanation, a possible explanation of the French paradox. Now, I admit that it is a quite simplistic graphical explanation, and we can criticize. However, I think it is a useful image of a complex interaction between many factors. We cannot explain the low mortality rate from coronary heart disease in France just by one factor, but we can discuss, for instance, the biological effect of wine. Wine, in terms of biology, it has been clearly demonstrated that alcohol influences platelet function. Whatever the way of testing platelet function, there are so many papers, ex vivo, in humans, showing that ethanol or alcohol decrease platelet function in a way very similar to aspirin, not using the same pathway. When you give aspirin to your patient, you interfere with the prostaglandin pathway. When your patients or people drink alcohol, they play on the thrombin-induced pathway. This is quite different. But this explanation, alcohol and platelet function, is not really satisfying because the way of drinking is also very important. For instance, this is a quite complicated graph, but you see this is an experiment in rats. Here the rats are only water to drink. Here they have alcohol, about 6% of their energy intake. Here red wine and here white wine. You see that there is a striking effect on platelet function when the rats drink alcohol, red or white wine. But if you stop alcohol in these rats, you are here, your rats are deprived for 18 hours. This is not exactly the same scale, but you understand that those we were drinking alcohol do have a higher platelet aggregation test than those drinking water. It means that there is a rebound effect, but the rebound effect is prevented in the rats drinking red wine. It means that in addition to an effect of ethanol on platelet function, there is also an effect on other substances present in wine, but in red wine, not in white wine. Well, the next question is wine more protective than other alcohols? There are many studies about that. Just this meta-analysis published in Circulation in 2002, these investigators found evidence of a significant inverse association between moderate wine drinking and vascular risk. They found a similar, although smaller, association in beer consumption studies. The latter finding, however, was difficult to interpret because no meaningful relationship could be found between different amounts of beer intake and vascular risk. Now, the pattern of drinking is also very important. This is a paper published in the British Medical Journal in 2010. The investigators compared two populations, one in France and one in Ireland. The two populations drink the same amounts of alcohol in terms of grams per day per person. However, the prevalence of binge drinking was higher among the Irish. This is very important because the mortality rate from cardiovascular disease in Ireland is much higher than in France, despite the same consumption of alcohol, but with different, completely different way of drinking. Never, they concluded, these investigators, that never drinkers, we were 7 times more numerous in Ireland at the risk of ischemic heart disease, similar to that of binge drinkers. No binge drinking, and if you start drinking, never stop. Well, and if your patient had a myocardial infarction, there is evidence that wine drinking is protective against a recurrence. Well, next question. What is wine? This is a very simple answer. Wine is a mix of ethanol and polyphenol. But if polyphenol are protective, the next question is tea protective, since tea is just water plus polyphenols? Actually, we have evidence from epidemiological studies that tea and flavonoid from tea are protective against myocardial infarction. Now, last question, are polyphenols bioactive enough to protect the heart? There are many proposed mechanisms to explain the protection of the heart with polyphenol. I have selected 2. First one, this is a paper published in Nature in 2001. It was an effect of polyphenol from wine on the endothelin synthesis. As you know, endothelin 1 is a potent vasoconstrictor, and some scientists say that it is a key factor in the development of vascular disease, in particular in acute myocardial infarction. When we study the effect of red wines or the different polyphenol extracted from red wines, we have a they show a significant effect on the synthesis of endothelin 1. But the white and the rosy wine did not. And the second mechanism, it is the one I prefer because it is my group that describe this mechanism. It is what we have called a fish-like effect of moderate wine drinking. Among people with cardiovascular disease, we have shown that for the same amount of fish and long-chain marine omega-3 fatty acid in the daily diet, those who were drinking wine had a higher level of this marine omega-3 fatty acid in their blood and in their cell membranes, which is what we call the fish-like effect. And this has been completely verified by epidemiologists in large studies. They also showed that wine drinkers had a higher omega-3 fatty acid. As you know, omega-3 fatty acid are considered as cardioprotective, even for the same amounts of this fatty acid in their diet. And finally, we have been able in a rat experiment to reproduce this effect of flavonoids, in that case, on the metabolism of omega-3 fatty acid. We are not able to say the exact molecular mechanism, but obviously when you give flavonoid to rats for the same amounts of marine omega-3 fatty acid in the diet, they have about 40% higher levels of this omega-3 fatty acid in their blood. Well, a conclusion, there is a consensus to say that French have a low mortality rate from cardiovascular disease. We don't have a full explanation for that, but apparently the way of drinking, it is a part of the lifestyle, is playing a role, maybe a small role, maybe a major role, I don't know. I thank you very much for your attention. And if you need more about our publication, you can go on PubMed, of course. And if you read French, if you understand French, you can consult my blog. Here is the address. Thank you very much for your attention.
Mr. Chairman, ladies and gentlemen, very happy to be here fostering attention to these nutritional issues in cardiology, which I think deserve more attention than currently is given. Nothing to declare. I will start with this photograph that is very dear to me because it was given to me by Professor Mario Mancini from Naples. And I invite you to try to recognize these two gentlemen here. This is Paul Dudley White, and this is a young Ansel Keys walking in the streets of a small Mediterranean village in southern Italy, in the region of Cilento, which is in peninsular Italy, during the performance of the so-called 7 countries study. And this is a tale of Mediterranean diet is really a tribute to Ansel Keys that if you simply go to Wikipedia, you will find this explanation. An American scientist born in 1904, died in 2004, a good example of habits linked to longevity, who studied the influence of diet on health. In particular, he hypothesized that different kinds of dietary fat had different effects on health. In addition to his role in establishing modern cardiovascular disease epidemiology, Keys was closely associated with 2 famous diets, the K rations formulated as balanced meals to combat soldiers in World War II, and the Mediterranean diet, which he popularized with his wife, Margaret. Science, diet, and health have been central themes of his professional and private lives. What is Mediterranean diets? We heard already a lot about these, but the main key points, I think, are a diet poor in calories, rich in complex carbohydrates with a low glycemic index, rich in fiber and vegetables, rich in alpha-linolenic acid, and in some areas of fish-derived eicosapentaenoic and docosahexaenoic acid, fish oils, usually rich in oleic acid from olive oil, with a moderate consumption of alcohol, especially from wine, as we heard, and rich in antioxidants from extra virgin olive oils and trans resveratrol from red wine. From extra virgin olive oil, quercetin, hydroxytyrosol, and linoleic acid, probably the most abundant ones. I will briefly go through these items, the proof of concept, mechanism, and some kind of thoughts regarding my take-home messages regarding nutritional factors as an emerging preventive approach. The proof of concept, the latest one, was given by this publication by the group of the PREDIMED study, Primary Prevention of Cardiovascular Disease with the Mediterranean Diet. 2 types of Mediterranean diet, one rich in nuts, one rich in extra virgin olive oil, compared with controlled diet over a period of 5 years, and look at the difference in this case in the incidence of composite cardiovascular endpoints, proving the concept that you can achieve something also with a complex intervention trial such as a diet. The second issue I want to address is related to mechanism, how this may occur. And we have to understand that in the pathogenesis of coronary heart disease, you have atherosclerosis inception at the beginning, then you have atherosclerosis evolution, the complication of atherosclerotic plaque, then you have the disruption, thrombosis, and then you have also the consequences of thrombosis, the effects on the myocardium and the susceptibility to arrhythmias. And here you have different possible endpoints, different possible targets, which have been the focus of research regarding components of the Mediterranean diets. This slide is very dear to me because it's a personal slide, occurred to be produced in 1994, where we studied endothelial activation in terms of, in this case, of the addition of monocytes to an endothelial monolayer that can be inflamed with an inflammatory cytokine, in this case interleukin-4, but you can do it with interleukin-1, TNF-alpha. And this is the effect if you pre-incubate the endothelial monolayer with the omega-3 or polyunsaturated fatty acid, docosahexaenoic acid. And this is, by comparison, what you can obtain by blocking one of the so-called endothelial addition molecules that are thought to be primary actors in the process of monocyte addition to the inflamed endothelium. And indeed, if you try to construct a concentration response curve with docosahexaenoic acid here on the abscissa as a function of the expression of VCAM1 protein, you find this concentration response effect that occurs for concentrations in the order of 10 to 25 micromolar that are thought to be nutritionally achievable of docosahexaenoic acid. How may this occur? This is an old-fashioned northern blot showing that the messenger RNA level, steady-state messenger RNA level, are reduced by the presence of DHA in the incubation medium with the need of pre-treating endothelial cells before the challenge with cytokine. And this brings us to the general machinery within endothelial cells that foster the atherosclerotic process, which is a kind of common theme in inflammation and vascular disease. You have a set of pro-atherogenic stimuli. You can put here interleukin-1, you can put the advanced glycation end products of diabetes, you can put endotoxin, homocysteine, to some extent, culminating in the activation of the intracellular machinery generating reactive oxygen intermediates, the most important of which, from the standpoint of vascular inflammation, is hydrogen peroxide. Hydrogen peroxide determining the activation of this transcription factor called nuclear factor kappa B that normally sits inactive in the cytoplasm, and when activated by reactive oxygen species through a complex process, there is the detachment of an inhibitor from the two active subunits that you see here, P65, P50, the migration of these subunits into the nucleus, the binding of these transcription factors to DNA sequence in the promoter region, and the elicitation of transcription of several genes that have NF-kappa B in their promoter region. And these include addition molecules, include cyclooxygenase 2, include molecules such as chemoattractants, such as monocyte chemoattractant 1, or factors that foster the multiplication of macrophages, such as MCSF. Indeed, many years later, we were able to demonstrate that omega-3 fatty acids can reduce the activation of this transcription factor, nuclear factor kappa B. This is a gel shift assay. This intensity of the band here corresponds to the binding of the transcription factor to DNA, retarding the electrophoretic mobility of the DNA sequences, and proving that in this condition, interleukin-1, there is the activation of the transcription factor. And here you see the blurring of this band here, meaning that the presence of docosahexaenoic acid in endothelial cells can determine a lesser activation of this transcription factor. This occurs also for other genes. In this case is COX-2 protein that is thought to be relevant in other processes of endothelial possible instabilization, such as the angiogenesis within the plaque. Indeed, the DHA may reduce also COX-2 protein and messenger RNA, and this is the general scheme by which this may occur, acting very upstream in the signal transduction cascade by which a cytokine or an inflammatory stimulus may activate the intracellular machinery, culminating in the activation of NF-kappa B sensitive genes such as VCAM1, COX-2, and many others. Coming to dietary polyphenols, we mostly focused our attention on two polyphenols, oleuropein and hydroxytyrosol, because these are some way the characterizing polyphenols of extra virgin olive oil. Remember that extra virgin olive oil Mediterranean diet was the one that performed best in the Predimed study. But also you see that you can study by the same mechanism also red wine polyphenols such as resveratrol or quercetin. And here you see that indeed these polyphenols act similarly to what we showed before for omega-3 fatty acids in terms of reducing the generation of reactive oxygen species, here measured by this fluorescence assay with dichlorofluorescein that reports on the generation of specifically of hydrogen peroxide within endothelial cells. Here you have a black monolayer in which this is the resting condition. This is the activated endothelium, activated in this case by formol myristate acetate, and here is the quenching of the pro-inflammatory phenomenon occurring when you incubate this monolayer with micromolar amounts of oleuropein, hydroxytyrosol, resveratrol, or quercetin, used at concentrations that are nutritionally relevant. And also you see that there is an inhibition of the activity of COX-2 that you can measure by the production of PGE2, or an inhibition of an end product of COX-2 activation, which is matrix metalloproteinase 9, which is thought to be important in the process of plaque instabilization due to the activation through MMP9 of a degradation of the fibrous cap and possibly the precipitation of plaque rupture. Not only this, because you have very complex effects of several Mediterranean dietary compounds, as well as sometimes of other nutritional compounds on platelet physiology, as depicted here in this interesting review that I invite you to read in the next issue of Vascular Pharmacology 2013, the September issue, where it's depicted the many possible endpoints by which nutritional components of the Mediterranean diets may inhibit platelet activation. And then you have evidence, as most of you recall, that there are mechanisms of arrhythmogenesis that can be blunted by some of these compounds, in this case, docosahexaenoic acid. This is the model of neonatal cardiomyocytes triggered by Wageningen inducing potassium current, triggering a kind of arrhythmia burst in neonatal cardiomyocytes, and this can be prevented to a large extent with a kind of membrane stabilizing effect very similar to what you can obtain with lidocaine, with local anesthetic lidocaine, that is also used as you know, in reducing ventricular arrhythmias in the setting of myocardial ischemia. And this goes hand in hand with the data that we have from the GC study, the GC Prevenzione study, in which on the background of a Mediterranean diet, the addition of omega-3 fatty acid was able to reduce cardiovascular mortality, but mostly, if you see in this sub-analysis, it was published by Roberto Marchioli 3 years after the publication of the main GC Prevenzione study, there was a gradient in the reduction of cardiovascular mortality, coronary heart disease mortality, and sudden death, attributing large part of this reduction in mortality occurring in GC prevention to the reduction of possible arrhythmias. Therefore, and this is my kind of tentative philosophical conclusion, we have multiple mechanisms of action of natural dietary substances such as omega-3 fatty acids and Mediterranean diet polyphenols, apparently mostly related to their ability to inhibit gene expression of pro-inflammatory genes, inhibiting redox-sensitive transcription factors, the most prominent of which being nuclear factor kappa B, and to some extent to inhibit arrhythmogenesis, which is a property relatively specific for omega-3 fatty acids. Now, these are the two final slides. Two opposite but not mutually exclusive strategies to fight against cardiovascular disease. One, I would say, is the traditional approach that the pharmaceutical industry is pursuing, to find one specific target and to try to hit with the magic bullet. The magic bullet hypothesis that stems in history from the studies by the German physiologist Paul Ehrlich at the beginning of the last century. The drug as a selective magic bullet. On the other hand, we may have drugs or dietary components or components that act as a general modulators of cellular function. And to use the words of Alexander Leaf regarding omega-3 fatty acids, but I think we can expand also to Mediterranean diet polyphenols, general, gentle quencher of pro-inflammatory, pro-thrombotic, pro-atherogenic vascular responses with a variety of final effects. Most probably acting also in concert, not only one single molecule, which means the difficulty in translating this knowledge coming strongly from epidemiological and intervention trial with the dietary interventions in formal trials with one single compound that we isolate from the context of the complex milieu in which the isolated compound is assumed and pretend that we can obtain or reproduce the same effect of the complex dietary intervention. So most probably acting in concert with not one single active molecule. And also, last consideration, most probably acting over a lifetime exposure, something which is very difficult to reproduce in the setting of a short-lived clinical trial. And major variants, therefore, I conclude, from drug strategies usually currently pursued, but with strong implication for public health. Thank you very much for your attention.
Postly, New York. One question I have is that relating your work to that of Professor de Lorgeril, your area around Chieti in his epidemiological map of Italy was the single area that had the highest incidence of heart disease. How would you explain that?
Well, first of all, I have to say that I've been a little bit surprised by seeing that data because I was not aware of this. But I also have to say that I would have raised, I stood up before because I wanted to be a little bit provocative on Michel's data, because France in this pattern always look dark green. And I think this doesn't always fit with the data that have been produced over time. I remember very clearly when Serge Renaud used to compare the platelets in the southern region of France, the region of Var, close to Nice, with the region of Moselle, which is very rich in butter. He took these two opposite regions as the extremes of the spectrum of cardiovascular disease in France. And I'm a little bit surprised by seeing this, let's say, homogeneous green behavior of, but this, I think, this can be postponed for the discussion later on. To come clearly to give you an answer, I don't have the explanation for that, but I'm also not totally sure about those data.
There were three, to me, important points around the turn of the century that changed cardiology. The three pivotal events were the issuance of the Nobel Prize to Professor Faergeman and his mates for pointing out the significance of nitric oxide as a signaling molecule central to the entire circulation. The second was a flat statement by a pathologist, pathophysiologist of renown, Russell Ross, who said, atherosclerosis is clearly an inflammatory disease and does not result simply from the accumulation of lipids, which we had been taught to believe. And the third was the paper in Circulation by Libby, Ritker, and Masary, who clearly said atherosclerosis is an inflammatory disease. To me, being a somewhat older generation, that was quite a revelation because we were taught differently, but it also opened up the search for the role that we could play in the future in terms of treating atherosclerosis at the right time. For on your far right, this is what we do mostly. We operate, we dilate, and we give drugs at an end stage of the disease. Maybe that's our duty as a cardiologist, but I believe we have another one, namely to somewhere before, perhaps as early as puberty, to start looking for the early evidence of the beginning atherosclerotic lesion. The French paradox has been covered. I think we all have learned very much about the truth, but the wine story stays. And that's what I would like to talk to you about a bit more. Castelnuovo was, I think, one of the people who used meta-analysis to the best of his knowledge to prove that you can reduce mortality by some 30%. Wine was the main factor. My good friend Jean-Claude Stoclet turned me around in 2004 when I began to try to figure out what in the wine really was the story. With this beautiful paper that I recommend you read, it is the New Testament to me. They worked in Strasbourg at the Institut Pasteur for a number of years in the mechanisms, and they were the ones who really pointed out that the NO production that we just heard about is stimulated when it is disturbed and preserved by wine products. What is it in the wine? There are phenolic groups, by themselves simple structures, but the multiples that are made in nature, and in wine you find some 500 plus of them, have the different characteristics. I want to point out what just was said at the end of the previous speaker. It is the mixture of that naturally occurring set of polyphenols in red wine that was always stronger than any mixture of the individual components. Also, wine is not always wine. On the top line, you find that the Saint-Emilion from Château Chauvin, a Merlot, from 1990 was very rich in polyphenols. A little bit lower from the same region, Château Bel Air, also Merlot from 1990, had only half of that content. The variations then in the various wines make partially the explanation for what we've seen in epidemiology that doesn't fit. Furthermore, it depends where you look in the grape which polyphenol you will find. 60% come out of the pits. The skin is very important if you're looking for resveratrol. Also the region is important. So with all these differences in mind, let's stick to what is important to us as cardiologists. Two groups, the flavonoids on your left, the non-flavonoids on your right. I think there are perhaps 20 of them out of the whole world of polyphenols that affect the human body in a significant manner. A person who helped greatly to elucidate this was Professor Corder. On your left, you find the linear relationship in terms of inhibiting endothelin. I think Raffaele was talking about that as well. On the right-hand side, you find the different concentrations, perhaps not easy to read for you, but on the far lower left, we're talking about the Australian wines, and the far right, the content in southwestern France, and the fact that in the department de Gers, where the Tannat grape grows nicely, people become probably older than any other region of France. An example is Madame Calment, who became 122 here at her 121st birthday, with on her, in the back on the right, her daughter and her grandchildren. So it's just an example, and it should perhaps lead me to say, I recommend that you take a good wine, drink 2 glasses of it today, and be happy. But my talk is about the polyphenols. So you have the alternative of 2 capsules. Why would I recommend those? It all depends on what you think of the endothelium. It is an organ that was sort of detected also around the century, turn of the century, as I pointed out before. It's a very thin layer on the inside of all arteries. It is an organ that, if you put it together and weigh it, is more than the liver. And in my medical school, they never talked about it. They thought it was sort of a little plastic sheet. It turns actually to be a crucial organ. I often talk to people when they say, what in the world are you talking about now? I said, it's like the current distribution system along the major highways. You have it more than 1,000 kilometers in your body, and if your production of NO is sufficient, then you have vascular health. If you do not, then you begin with atherosclerosis, as I will argue. We studied different kinds of wines, and particularly from different grapes, and found differences that are important. So if you go tonight and drink a glass of wine in Amsterdam, I recommend that you look for a Merlot. On average, you get out best in terms of the polyphenolic content. Better still is if you took a wine from the region of the Gers, from Madame Calment, because at very small concentrations, with an intact endothelium, you see here, you have a dramatic relaxation of your blood vessels. The first animal models in an intact animal came, not so funny perhaps, from Australia. And the conclusion of that experiment, this simple experiment, was that it wasn't the wine itself, but the polyphenols in it that seemed to have the effect on that particular study. We did an analysis, therefore, on mice that were genetically modified in Leiden, and we found on your far left that the control values over 4 to 8 weeks remained around 12 milligram, micrograms, and so forth, whereas if you used a very small amount of the red wine polyphenol mixture that I'll be talking about more, you already had within 4 weeks a significant reduction in CRP, which at the time was controversial and still probably is, but still is for all us cardiologists a very good indicator of inflammation. Actually, these small amounts were just as significant as using fibrate on your far right. I sum up the experiments that we did in Strasbourg with Professor Stockler, Professor Chieti, and we formulated a beneficial cascade, components of which you have heard in the previous talks. There is clever evidence, totally convincing, that NO production, vascular relaxation, endothelial inhibition are vital. There are anti-inflammatory components, which have not been discussed much except by Raffaele. I will go into that. There is evidence of anti-cholesterolemic effect, anti-thrombotic effect, we heard, together antioxidant action. In short, the wine polyphenols have vascular protective and hopefully anti-atherosclerotic activity. In the middle, Professor Chieti, a wonderful group to work with in the Alsace. This paper appeared now exactly with a few more days 8 years ago on the ESC program. It was the first time that the scientific committee could be convinced that it was worthwhile to talk about alcohol, polyphenols, inflammation, and atherosclerosis. Struch presented a paper that he had a study carried out some time before, and on which many of you may have participated because it were the assistants of the University Hospital in Barcelona who carried out a study comparing pure alcohol with the same amount of alcohol distilled from the Merlot grape of his father's vineyard. They were, keep that in mind, allegedly healthy assistants. They had no evidence of heart disease, no evidence of any disease. They followed a strict statistical design, so-called prospective crossover design, so that the patient, each individual, is compared to himself. I say patients, I don't mean it, they were volunteers. And the results were quite remarkable. Nobody had expected that in a normal healthy male assistant in cardiology in a university hospital, you have an elevated CRP. But this chronic inflammatory state, we now realize it's much more prevalent than it was at the time. After using the red iron intervention, the values declined, so did the agglutinins, VCAM, ECAM, interleukins, and a number of others. So when I was provoked in saying, prove it to me that in humans these stories can be reproduced and that they work, I went to Amsterdam, my friends Caterina and Stroes, and Madame Broekhuizen, who was then an assistant also in training. We did a study we called PRIME, polyphenols from red wine remnants, the skins and the pits, dried in a powder, and we tried it out on people with the metabolic syndrome, which allegedly is a precursor of atherosclerosis. After 4 weeks placebo, 4 weeks washout, 4 weeks polyphenols, we compared the groups, and we also did individual studies after provocation with the flow-mediated dilatation measurements in the forearm. I summarized the studies because we had many data. We studied some 50 different biomarkers, bioindicators, and to our great surprise, because we used a very small dose, since the ethical committee didn't want to take any risks with wine, we used 500 milligrams, which I still think is the recommended dose for today, and we saw that MCP1, again, this was mentioned by the Caterina, and MIF were significantly reduced. Also, there were changes in the flow-mediated dilatation. What is MCP1? What is its role? It's monocyte chemoattractant protein. It attracts the monocyte to sites of endothelial injury. It is associated with the onset of cardiovascular disease. If you block it in the animal, you can stop experimental induced atherosclerosis. MIF is macrophage migration inhibitory factor. It's a very prevalent biochem involved in many processes, again associated with the onset of cardiovascular disease, and if you block it, you can reduce pre-existing plaques. Bernhagen and his group in Aachen have studied it, and to sum up their results, each red dot indicates a point where MIF is active in the inflammatory process on your endothelium if you begin to develop atherosclerosis. I don't have the time to go each of the individual. Let me assure you that if you could slow down MIF, it is a good thing to do. So we interpreted the PRIME study in the metabolic syndrome as a precursor of atherosclerosis as being positive in that the polyphenols reduce the adhesion and arrest the inflammatory action. And we had a hypothesis then, could this have maybe the beginning of the onset of atherosclerosis? I showed you this before. Now in the particular area where it's written, so begin treatment here, we have a slope which reflects the increasing, shall we say, presence in terms of quantity of these various inflammatory indicators. We heard about VCAM and ECAM as agglutinins. I've tried to explain MCP1, MIF, which are inflammatory indicators, and so forth and so on. So couldn't this be the place you should attack? I made some cartoons, my son did. You see here the leukocyte coming happily along in an artery. and being attracted to the endothelium by the chemoattractants, they get to a stage which is called slow rolling, and we believe that the red wine polyphenols block specifically MCP1 and MIF at this particular point, and thereby stop the inflammation. They stop the inflammation because if that is done, we do not have adherence, and if we don't have adherence, we don't get the birth of a plaque, and we avoid this ugly lesion. Along came Jupiter. Jupiter was a fantastic study. It is very infrequently talked about in Europe. Yet it is a study that was done on both sides of the ocean. It was based on the assumption that, and I've had that same experience in our cath lab in Rotterdam, patients come in with advanced coronary heart disease and have a normal cholesterol. So it was based on the fact, what Russell Ross said in 1999, you do not necessarily have to have an elevated cholesterol to get a very inflamed endothelium. And if inflammation precedes lipid deposition, how could we treat it? So they selected 800,000 individuals on both sides of the ocean, and they had two criteria for selection. It had to have, as an individual, healthy, an elevated CRP and a normal LDL, at least normal by the levels by which we treat. Out of these, nearly 18,000 were found in a number of countries, and this included women, very important point. And the study was stopped prematurely as the mortality decreased, even in a group with a low normal LDL, but with an elevated CRP. What was the explanation? Should we treat a biomarker before our symptoms? I don't think the books have been closed, because they talked about a statin. Could this also be achieved with a wine grape? There was the European prospective investigation into cancer, which turned into the EPIC Heart study, which also is very infrequently cited. Truly impressive study. 313,000 men and women were followed from 8 European countries for an average of 8.4 years. Think of the work. They found, on average, that if you had 5 to 7, or preferably 8 portions of vegetables and fruits, and you ate that every day, 8 times 80 grams is a lot of fruit and a lot of vegetable, you can achieve a reduction in fatal coronary heart disease with this diet with 20%. We're getting close to figures that are bandied around for the Mediterranean diet. It is interesting, though, that if you talk to the people who did the study and you ask them, who ate that? They say that was just 18%. And these 18%, incidentally, when I asked them what did they eat, it was not the citrus fruit, it were not the hard-skinned fruit, it was the other fruit group. That was not very specifically defined, but that contained the grapes and the berries and so forth. So circumstantial evidence, but impressive nevertheless. The last study that I will talk about was a direct study from resveratrol on atherosclerosis. These were mice, like we used in Leiden before, genetically modified to develop atherosclerosis in the ascending aorta, and we compared resveratrol with atorvastatin and the use of both. And you see that there was a slight higher reduction in the amount of atherosclerosis area in the ascending aorta with resveratrol, not too significant. Left upper hand corner gives the control, the mice that were given the atherosclerotic diet. You see the thickening of the wall. You look at the right hand side, that's the resveratrol. You can argue that in the upper right corner there still is some lesion. So be it. It's a lot less than in the control. Atorvastatin, left lower, has slightly more evidence. The two are not incompatible and actually are also not reinforceable. I cite just one study out of the recent literature. Tomei Carneo in the American Journal took what you would want to know, They did a prospective, randomized, parallel study in 75 patients who all were on statins for CAD. It doesn't say in the paper how they proved that, but that's why they were. And they gave them 2 diets, or 2 treatments, placebo or the polyphenols, one with extra resveratrol, a minute amount actually. You see that that group had a marked decrease in the CRP, as we had shown, as we had not shown, but they had shown, a decrease in the tumor necrosis factor alpha and some others, and these are then, I would think, among the first data that are now coming in that show that such a diet with polyphenols can be considered as perhaps early treatment of atherosclerosis, certainly preventive. I sum up the data that Professor Chieti has put in the literature. We have primary prevention on your left-hand side by treating the endothelial dysfunction before there is atherosclerosis, mainly by vasodilatation and decreased vasoconstriction, but also by decreased platelet aggregation. I had no time to show the evidence. And under consideration right now, and in some very interesting studies positively reported, is also a action on the smooth muscle cell with decreased VEGF, decreased matrix metalloproteinase activity, perhaps to preserve an atherosclerotic lesion in a stable state. That's speculation. I sum up. On the left-hand side, you find that there are many preventive and pro-integrity influences on the endothelium, proven without a single doubt, also in man. On your right-hand side are some convincing data in the animal, and we are working on the human, which would suggest that you even can get to plate regression. Certainly plate stabilization is what we should be after in the first instance. We would then have not only from this food substance a primary preventive, but also secondary preventive action. I end with this slide because I think it's sobering. If you read it carefully, 2,600 years before Christ, the Chinese knew what to do. Superior doctors prevent the disease. Mediocre doctors treat the disease before it's evident, and I'm sorry for those who are interventionalists. Inferior doctors treat the full-blown disease. And that was Hung Lee who said that a long time ago. I thank you for your attention.
Thank you, Mr. Chairman, and thank you for the invitation to present at the ESC Congress on the potential vascular benefits of chocolate. Before I start, just a historical declaration of interest. My department were given a small grant from a Swiss chocolate manufacturer in 2009. So the whole interest in the vascular benefits of cocoa started with population-based studies where they looked at Kuna Indians living in the islands off the coast of Panama. And they were intrigued that they had a low incidence of hypertension, even with increasing age. And of particular interest to the investigators from Harvard, led by Hollenberg, were that when they migrated to Panama City, this protective effect of age and blood pressure seemed to disappear. And what was it in the environment that could be stimulating this change in incidence of hypertension? So when they looked at the diet, they assumed it would be salt and other traditional factors. But the most striking difference that they saw was that the islanders seemed to consume over 5 cups of an unprocessed cocoa drink per day, and that when they moved to the city, this didn't happen anymore. And actually, when they got analysis of this unprocessed cocoa, it was very rich in bioactive compounds called flavonoids. Now, you've heard a little about flavonoids in several of the other talks, but I was assuming I was speaking to cardiologists who may never have heard of flavonoids before. So just to briefly go through those, there are thousands of flavonoids present in plants, and they're present in many fruits, vegetables, and processed foods. There are 6 main subclasses. The isoflavones were almost exclusively associated with soy, the flavonones present in citrus juice, and the anthocyanins in berries like blueberries, strawberries, black currants. But of particular interest in relation to cocoa are a class of compounds called the flavonthiols. So what are the potential bioactive compounds in flavonthiols? Well, these have been studied quite a lot over the last decade, and in particular there's interest in the catechin, proanthocyanin, and the epicatechin content, with particular interest in epicatechin, with the structure shown over on your right. The biological effects of these compounds aren't completely known, but there are a number of potential mechanisms of action. What is clear over the last few years is that the biological effects in relation to cardiovascular disease are beyond antioxidant effects. So that classic hydrogen-donating antioxidant activity can't explain the observed in vivo bioactivity that the flavonoids seem to have. What's more interesting is their potential effects on cell signaling pathways, with particular interest on their effects on NADPH oxidase and nitric oxide. Also their anti-inflammatory effects and their effects in inhibiting glucose transporters, particularly GLUT2 and GLUT4. So the million-dollar question, which everybody wants to know, and there isn't really a clear answer, and I will wrap up at the end with my best guess, is chocolate healthy? Is dark the healthy option? What's the best chocolate to buy, and how much do I need to eat to have a heart health benefit? I think it's important to know a little bit about the chemistry and the processing of chocolate before we go through the population-based and randomized control trial data. What is clear is that it's the cocoa content that's important for any potential heart health benefits. The origin of the cocoa, the processing, the storage, how it's prepared, all alter the chemical composition and the flavonthriol content. Raw cocoa is almost always very rich in flavonthiols, and it's what people do with it afterwards that alters the levels that are present in the resulting chocolate bar. Cocoa itself is also very rich, but processing does remove many of the flavonols. What's interesting is that one of the processes which actually removes a lot of the flavonoids was discovered in Amsterdam way back several hundred years ago. And it's called Dutching, or Dutch processing. And what these Dutch food chemists realized was that by adding an alkaline, they could solubilize the chocolate and make it taste much better. But it improved the taste, improved the texture, and eliminated the bitterness, but also in many ways reduces almost all the flavonoids as well. As a general rule, dark chocolate does tend to have a higher cocoa content, so it will have more flavonoids. But of course it does depend how it's processed. And actually it's the bitterness in chocolate that the flavonoids are responsible for. So one of the earliest studies which caused significant interest in the field was a very small RCT with 44 middle-aged subjects, men and women, who were fed either 1 square of dark chocolate or 1 square of white chocolate over 18 weeks. And this was published in JAMA, and quite remarkable effects on blood pressure, given the duration and short study. So no effect of white chocolate on blood pressure, but a 3 millimeters of mercury change in systolic blood pressure, and almost 2 in diastolic blood pressure. So a number of epidemiological studies have been conducted, 6 prospective studies and 1 cross-sectional study. And these were very nicely combined, and a meta-analysis conducted, led by Oscar Franco, in fact, and published in the BMJ a couple of years ago. And what they showed when they pulled all cardiovascular outcomes, that includes MI, stroke, and all the others, there was a relative risk reduction of 27% when you compared those who ate high amounts of chocolate to low consumers. But high levels of chocolate median intakes were of the order of 10, 20 grams a day. When you dissect then the different health outcomes, and here we have the data for heart failure, there were only 2 studies, but no evidence of beneficial effects of higher chocolate intake. And for stroke, there appeared to be significant benefits, with a 29% reduction in risk in the BMJ study. In a more recent study, where there were 2 additional studies, they also showed a significant reduction, a 19% reduction, when you compared high to low consumption. So several years ago, we undertook a meta-analysis of the intervention trials that have been conducted to date on cocoa and chocolate, which was published in AJCN in early 2012. So when we set up to do the meta-analysis, we were of course interested in outcome data as well. But when we conducted our search, it was clear that all of the studies that have been conducted to date are of short duration. So it ended up being a biomarker of risk study. When we conducted the study, by the time we had finished our review of all of the literature, there were 42 included studies. And of those, about 60% were funded by industry. And I'll come back to that when I show you the data. So this is a summary of the endpoint data and the effects that we showed when we pulled the data. So you'll see the biomarkers, and firstly looking at HOMA-IR, where we showed a significant reduction in HOMA-IR following chocolate intervention, and this seemed to be driven by a significant reduction in serum insulin levels. For flow-mediated dilatation, the acute effect was significant, a 3% increase following chocolate intake, and chronic intake, a smaller but sustained improvement in FMD. For systolic blood pressure, there was no effect of cocoa, but there were significant beneficial effects on diastolic blood pressure and MAP. In all, there were 42 acute or short-term duration studies, but the longest duration study was 18 weeks. And actually, there were only, I think, 7 studies that were more than 6-week duration. No effects on lipid levels or CRP levels from the data that we had. The other area that we were interested in is there is lots of interest, particularly in epicatechin as a potential bioactive constituent of chocolate. And what about dose? So when we looked at the effects, interestingly for FMD, for acute studies, dose seemed to be important, i.e. the higher the dose, the greater the beneficial effect on FMD. But interestingly, this did not, we didn't see this when we looked at chronic FMD. And for both systolic and diastolic blood pressure, dose seemed to be important in that there seemed to be beneficial effects only at a dose greater than 50 milligrams per day. Another issue that we looked at was duration, but again remembering that the longest term study was 18 weeks. For FMD, there was no significant effect of duration, but for HDL it was interesting that it was only in studies of 6 weeks duration or longer that there was a significant beneficial effect on HDL cholesterol. And actually this fits with all other nutrition interventions, that you don't get effects in short-term studies. There were no clear effects of duration on blood pressure or on triglyceride levels. And one of the big issues when we conducted this review is the lack of long-term trials. I also mentioned industry funding, and about 60% of the trials that we included here were funded by industry. But we did a sensitivity analysis on our 2 main outcome measures, which were FMD and HOMA-IR, and they stood up to this sensitivity analysis, suggesting a real effect. So this meta-analysis focused on primary prevention in healthy subjects, and there have been to date very few secondary prevention trials. But let me just talk you through a trial that we conducted, funded by Diabetes UK, a charity in the UK, where we took women with type 2 diabetes who were on conventional therapy, so they were all on statins, for example, and we looked to see if you could get any additional benefit from consuming flavonoids in the longer term, so it was a 1-year intervention. We know that menopausal women with type 2 diabetes have poorer metabolic control than male patients, and that cardiovascular disease is the dominant clinical problem despite the conventional therapy. So it was a 1-year parallel design. 93 completed the trial, and we looked at the effects of chocolate. Now, it was a joint intervention of isoflavones present from soy and flavonthreols and cardiovascular risk biomarkers. And over the 1 year, we didn't find any effects on intermedial thickness, but we did find improvements in arterial stiffness, pulse pressure variability improved, and pulse wave velocity was reduced. We showed an improvement in lipoprotein profile, even though they were already on statins, albeit small effects, but still potential clinical relevance. Insulin resistance and insulin sensitivity was improved. And when we looked at the UK PDS score, it attenuated the 10-year cardiovascular risk. So this suggests additional benefits of flavonoids to standard drug therapy in potentially managing cardiovascular risk, as well as its potential role in primary prevention. So I have a summary slide, and then I will talk about potential public health or sort of patient advice. So I think there's been significant progress in understanding the relative importance of cocoa, because really this is an area that really only started 10 to 15 years ago. We know that it improves blood pressure, insulin resistance, lipids and FMD in short-term studies. And actually the potential clinical relevance is important too. Certainly from Framingham they showed that a 1% increase in FMD was associated with about a 12 to 13% reduction in risk of cardiovascular events. We showed a 1.3% increase in the short-term studies. And this, together with a reduction in home IR, may well be of clinical importance. Can chocolate be a health food? Well, I think we need to be very careful there, because a 50-gram sort of average bar of chocolate contains 50 grams of fat, a lot of which is saturated, 230 kilocalories, and this is about 10% of total energy intake. Cocoa is a key constituent, but there are many other sources of these flavin-triol compounds, and they're not exclusive to cocoa at all. And down on the right-hand side are some examples, and I will talk in a minute about the relative amount of each of those foods you would need compared to chocolate. But the one thing that the field really needs is much further longer-term trials. So we're seeing efficacy in 18-week and shorter duration trials, but is this sustainable in the longer term? We need validated clinical measure outcome data. We need clear dose response studies. We also need to make sure that we balance potential risk benefits and look at the totality of health effects rather than just focusing on a particular benefit to cardiovascular health like blood pressure or lipids. And another issue, of course, when you try and pool studies is that there's wide variability in the composition of the foods that are used. They're characterized differently, so it's very hard to pool data for meta-analysis. We also need to make sure that we have matched controls, so white chocolate is not particularly good, not a particularly good control for dark chocolate, for example. And we also need to look at measures of compliance, like measuring levels of metabolites. And of course, the whole issue of supplements v food is another issue that needs to be addressed, because just because chocolate may be beneficial doesn't necessarily mean that the specific flavonoid content is important. So back to those million-dollar questions, and I think the advice is it's a moderate amount of the right type of chocolate, but we really need labelling of the flavonoid content, because although as a general rule of thumb, the darker the chocolate, the higher the percent cocoa is a good estimate of the flavin-triol content. It's not always the case, in particular because of this Dutch processing method. We need longer duration government-funded trials. And what is also important is that there are many other sources, and of course, because there's a significant industry interest in this from the cocoa companies, it gets an awful lot more press than, for example, apples or indeed tea, for example. But 2 squares of dark chocolate equate to have the same flavin-triol content as 1 apple, and there are some apples, like I think pink lady apples, which are particularly rich in flavin-triols. 1 teaspoon of unprocessed cocoa. So not drinking chocolate, but the one that you would use in cooking, a small glass of red wine, or a cup of tea. And I think the other thing to remember too is that there are many other flavonoids that have potential heart health benefits. And one particular class of interest are berry fruits, which contain anthocyanins. And earlier this year, we published a paper working with the Harvard cohorts showing that you can get a 32% reduction in risk of MI in young and middle-aged women when they eat several portions of berries every week containing anthocyanins. And we're now doing a 6-month dose response study with anthocyanins to try and understand more about heart health benefits of this class of flavonoids.